Hey there, this is Glenn Adams, and today I'm going to be presenting my master's project on unstable angina pectoris. Throughout this presentation, I will just refer to it as unstable angina. During this presentation, we're going to cover the pathophysiology of unstable angina, some signs and symptoms, the clinical assessment, diagnosis, and treatment. The pathophysiology of unstable angina falls under an umbrella with two other diseases. So the umbrella is acute coronary syndromes, and it encompasses ST elevated myocardial infarctions, non-ST elevated myocardial infarctions, and unstable angina. These three disease pathologies are all in the same umbrella because they share the factor that they're all based on the O2 supply of the heart and demand being in an imbalanced state. Unstable angina specifically has a stable O2 demand, but a decreased flow in O2, which is then why your patient begins to have symptoms. The disease process of unstable angina is typically due to plaque buildup in the heart vessels and therefore shares very similar risk factors with coronary artery disease, being male sex, diet, like a sedentary lifestyle, and smoking. Signs and symptoms of unstable angina typically include the patient will have worsening chest pain, or they'll have chest pain at rest that isn't relieved with nitroglycerin, or they could have an increase in their chest pain in terms of the frequency, duration, or the intensity. In terms of the clinical assessment, once you've established some signs and symptoms, you're going to want to order an EKG, ideally within 10 minutes of the patient presenting with these signs and symptoms that are indicative of unstable angina. You're going to look at the patient's vital signs and also do a physical exam. With the physical exam findings, it's mostly used to rule out other disease pathologies. For example, if a patient comes in with chest pain and you want to rule out musculoskeletal causes like costochondritis, you could palpate their chest and rule in or out costochondritis based on the presence or absence of reproducible pain with palpation. Some exam findings that are more indicative of unstable angina could be a paradoxical splitting of S2 or S4 heart sound and or a new mitral regurgitation. With your physical exam, you're also going to want to rule out other major causes of chest pain like a pneumothorax. One big factor it's important to consider is that unstable angina and NSTEMIs clinically present very similarly. And so on the next slide, we're going to talk about how you differentiate one from the other using cardiac biomarkers. For the diagnosis of unstable angina, like I mentioned on the last slide, you're going to want to order an EKG. If the patient is having an ST elevated myocardial infarction, then the ST segment will be elevated. In an NSTEMI, the patient could have inverted T waves or other signs of ischemia. And then with unstable angina specifically, the EKG might show old evidence of ischemia, so like inverted T waves, or it might be normal between attacks of chest pain. With the cardiobiomarkers, like I mentioned on the last slide, in an NSTEMI, these biomarkers will be elevated, and the way you differentiate this from unstable angina is that the biomarkers will be within normal limits. The gold standard for diagnosing unstable angina is angiography, but that is not always necessary. It can be clinically indicated if you're considering revascularization. Treatment for unstable angina, like most other disease pathologies, starts with lifestyle modifications. One of the big ones being smoking cessation. Another one that providers should stress is diet modifications, as well as physical activity. When it comes to pharmacological treatments for unstable angina, there's two categories. One being medications that have a proven reduction in mortality, and the other category being medications that have no proven mortality benefit but can help symptom control or quality of life. For medications that do have a proven reduction in mortality, this is going to be antiplatelet therapy. Your patient's going to be on aspirin and or clopidogrel. They will also need to be on a cardioselective beta blocker like metoprolol. They'll be on an ACE inhibitor like lisinopril and a statin. Medications that have no proven mortality benefit but can help with symptom control and quality of life are going to be the non-DHP calcium channel blockers, so either verapamil or ditalazam and nitroglycerin. Ultimately, the cure for unstable angina is revascularization with PCI or cabbage. These are the references I use to find the most up-to-date information on unstable angina. In this presentation, we went over the pathophysiology of the disease, some signs and symptoms, the clinical assessment, diagnosis, and treatment. I hope this helps you guys with your clinical knowledge and our upcoming boards. Thanks.